Thank you to the Eunice Joyce Gardner Charitable Foundation for its leadership support of the Health Channel.
Welcome to Unequal Access, Confronting Racial Disparities in Health. I'm Carla Hill. Good health is important. Getting annual checkups, screening for disease, and access to the right foods all can help keep you healthy. But what if your race or ethnicity makes that more difficult? It's a reality for some Americans today, and that's the focus of our town hall. Before we begin, let's take a quick look at where we are now. The number of people in good health is not the same across the board. According to the CDC, nearly 20% of Black people are considered to be in poor health, as more than 16% of Hispanic people. For the white population, a little over 13% are categorized as being in poor health. Historically, many have contributed those differences to a weakness or frailty of the race, but you'll see tonight those characterizations are simply false and clearly not supported by science. We have a great panel of experts to discuss the problem and answer your questions, so let's introduce them. Dr. Hernandez is the Vice President, Medical Education and Chief Health Equity Officer for Baptist Health South Florida. Dr. Rimsky Denis is a structural and interventional cardiologist. Dr. LaToya Lewis is an associate professor of clinical nursing at the University of Miami School of Nursing and Health Studies. And Jamaal Jones is the founder and health law attorney at Jones Health Law. Welcome to all of you. Welcome, Dr. Lewis. Thank you. So I want to begin with Dr. Hernandez. You know, at the beginning of the show, I quoted some numbers about where we stood in regards to overall health and highlighted the past perception that there was something intrinsically weak with different races. So what's the source of that information?
Yes. Good evening, Carla, and thank you for having.
Of course.
Increasingly, race is seen as a sociological construct, but if we look back to the origin of the racial classification of races were put forth as hierarchical biological that drove the differences that we see in human populations. You know, the idea that Black people were inferior or even subhuman was put forth as a justification for enslavement. And there were a number of beliefs around that. Our third president, Thomas Jefferson, in his notes on the state of Virginia, Black people had weaker lungs, a weak pulmonary apparatus. And a couple decades after that, a physician said about quantifying that when the spirometer, which we use to measure lung function, was developed, and quantified it at about 20%. To this day, there is a correction in spirometers that puts it at about 15%, which can result in the underdiagnosis of pulmonary conditions. So we still, we don't have the same beliefs, but we deal with some of those vestiges still today.
This is true, and I'm wondering, as our audience might be, what causes health disparities? There are many factors, including that some are non-medical, called social determinants of health. If we, take a look, economic stability, educational access, healthcare access, even one's neighborhood and physical environment, social and community contacts, and access to healthy food. Dr. Lewis, I'm going to throw this over to you. How does economic stability play a role in health?
So economic stability has a key aspect where we're looking at access to health care. We're looking also at food deserts. Many of you may or may not be familiar with those terms, where individuals are not having equitable access to healthy and nutritious meals. Mm-hmm. In addition to that, another aspect regarding access focuses on aspects of socioeconomics. It also focuses on aspects of health literacy. So there are multifaceted aspects where it comes down to individual state of health.
Thank you for that. And Dr. Denis, what about educational access? Why is that so important to building overall health?
That's a great question. We know that individuals who are educated, particularly on health-related issues, have better outcomes when it comes to achieving optimal health. So we know that obtaining access to information with regard to great health and things that individuals can do to prevent certain disease processes, can ultimately have long-lasting effects on not just the individual themselves, but also their communities, and their children. That being said, education is a key issue. Prior to several decades ago, many individuals and minority communities were prohibited from receiving, such accesses to, this education. So we want to make sure that, this information is, as widespread as possible, so that we can decrease some of these disparities that we're discussing today's topic.
Thank you so much, Dr. Denis. Jamaal Jones, I want to piggyback on some of the things that Dr. Denis talked about. It's amazing to me that you have a health practice. So what about the neighborhood and physical environment? Can you explain how that can affect someone's health? What have you experienced in your practice with regard to that?
Sure. Carla, thank you for having me here this evening. It's a pleasure to be here. So someone's neighborhood and physical environment not only refers to the location a person resides in, but also the external surroundings and conditions that influences a person's health. The neighborhood and physical environment factors that affect someone's health would be the individual's access to healthy food, exposure to environmental hazards, access to recreational spaces, and proximity to crime and violence. Any of these social determinants can lead to a host of issues, right? So, for example, we have obesity and diabetes. That's typically caused by a lack of access to healthy food and recreational spaces. Respiratory problems and cardiovascular disease, that stems from exposure to environmental hazards, or even hypertension and chronic stress and depression, that in most cases, or many cases, stems from an individual's proximity to crime and violence.
Thank you so much for that, Jamaal. Going back to Dr. Hernandez, social and community context, what does that mean?
So the social and community context, as my co-panelists are referring to, that's the backdrop in which we live, right, and interact and either thrive or don't thrive. Things like access to adequate resources, to healthy food, to education, to jobs, to good health care. Those are factors that have to be looked at and considered when we to understand some of the poor outcomes that we see affecting particular communities that are not having as healthy and conducive that social backdrop.
Thank you so much for that explanation. I want to touch on another aspect that can affect the health of underserved communities, and it's called structural racism. It refers to the ways in which society fosters racial discrimination through mutually reinforcing systems of housing, education, employment, earnings, benefits, credit, media, healthcare, and criminal justice. Before we get into those factors, I want to show you a video that asked people their thoughts on what it will mean to end structural racism.
Ending structural racism means really having a place to start.
A legacy for my children.
A river of joy and freedom for all people.
That healing happens on all levels, both collectively and individually.
Creating space for historically marginalized populations to take on positions of leadership and power in our society.
It means that young people will thrive. It means that liberation will be happening. in real time.
There is enough resources, there's enough power, there's enough will in order to take this challenge on.
Working to build community power so we can transform the systems and structures and policies and practices that underlie inequity and racial injustice.
So compelling. Dr. Denis, how does structural racism lead to poor health outcomes?
Well, structural racism leads to poor health outcomes in many ways. There is something called implicit bias that oftentimes physicians and clinicians are faced with, where discriminate against patients for a host of different reasons. In addition to that, this leads to issues with iatrophobia. Patients themselves become fearful of the healthcare system in and of itself. These factors, in addition to a host of other factors, can cause patients to not access care the way that they should, cause physicians to not deliver or render services in the way that they should in efforts to achieve the health that we would like to see amongst patients. So with these factors, ultimately see how there's a storm that is ultimately created whereby patients are not receiving the care essentially that they should.
That is, I've never heard of that word in terms of a phobia for doctors. I want to move over now to Dr. Lewis. As a healthcare professor, you can talk about structural racism with the education system. And, how do you combat that?
So there are several ways to combat structural racism. Some aspects include to doing a deep dive with curriculum and seeing how cultural sensitivity can be fused throughout various curriculum. Another aspect is incorporating various interprofessional activities such as simulation and other discussions among healthcare providers or future healthcare providers about how do we address the holistic needs of patients, which include cultural aspects, which it also includes religious aspects, spiritual aspects, and then common preferences of a certain community. And the third aspect is then incorporating some case studies and discussions of individuals in various classrooms, from nurses to other healthcare providers, physicians, pre-health, physical therapy, because we all have an impact on patient care. Bringing these individuals together and talking about their personal perspectives and supporting the research, supporting the different diagnoses and illnesses, and bridging the gap to promote a more culturally aware environment. We have a question and a comment from someone watching on Facebook, and we want to thank you so much, Sonia. Unfortunately for Sonia, her grandmother passed. They are of Hispanic heritage. Her grandmother passed of congestive heart failure, I believe. Please forgive me if I've misspoken there. But one of the things that she wanted to bring up was that her grandmother didn't speak English, and it didn't seem that there were people that cared enough to find out more about how she was feeling. What are you seeing in the healthcare space? Any of our guests can chime in, and I think it speaks to what Dr. Lewis was just talking about, beginning with teaching healthcare providers from the very start. Any comments for Sonia?
I'm so sorry for your loss, Sonia, and you bring up a key point. We have a responsibility to educate our future clinicians across the health professions to ensure that they're providing culturally responsive care. That starts with ensuring that everybody has access to an interpreter if it's needed, to materials in their preferred language, and that we're partnering with them to ensure that the care that we are offering is aligned with their cultural background and their preferences. So I'm really sorry for your loss and your experience.
Thank you so much for that.
I would say that I'm sorry for your loss. Please. I would say I'm sorry for your loss as well, Sonia. We know that through many studies. Many studies have shown that African Americans and minority individuals, in addition to Hispanics, who have heart failure, these individuals are oftentimes referred to cardiac rehab, which is shown to improve outcomes with regard to mortality. Right? We know that these individuals are referred less likely for cardiac rehab. We know that these individuals who are candidates for ICDs or intracardiac defibrillators, right? These individuals are referred for intracardiac defibrillators on a lower rate. And when it comes to individuals who don't speak English, these individuals oftentimes don't receive the care or services and the education in their languages the way that they should receive that information. And studies have shown that this ultimately leads to decrease in health outcomes and ultimately poor outcomes with regard to mortality. And one of the reasons why I wanted to come back to South Florida is because we have individuals from a host of different backgrounds who don't speak English. We have undocumented individuals. I myself is of Haitian descent. I've seen and I've witnessed on many occasions where an individual like your mother who speaks Haitian Creole, who has heart failure, who has an ejection fraction of 15-20% and is at increased risk of mortality, isn't given the proper information in their native tongue, right, to ultimately help that individual achieve a better health outcome. And many of these individuals I've witnessed as a medical student and also as a resident ultimately end up succumbing to death or poor outcomes because of that lack of connection. So it's something that we as healthcare providers and we as a community need to work on much better to help decrease this disparity that currently exists.
Mm-hmm. Thank you so much, Dr. Denis. We have another great question from Deborah. And Dr. Lewis, I want to target this toward you. Deborah wants to know how often health literacy is taken into account when designing healthcare curriculums, healthcare paths. And I know this is something you deal with every day.
Yes. So an aspect of healthcare literacy that is important is establishing what the average individual or our patients, what grade level it is. Other aspects we want to look at is in regards to the illness, what the prevalence of the illness is or percentage of patient population has a particular illness, so that we can make sure that the health information is credible, that the health information also reflects not only medical terminology, but it also reflects common words or terminology that we will then say to our patients. So other aspects of that also include is providing health information in a multiple variety of formats. So not only written information, there's technology now in healthcare that we incorporate videos. In addition to that, there are opportunities with telemedicine that we're able to remotely talk to other healthcare providers. So we're taking health literacy and health information to another level because we want to make sure that we're meeting the learning needs of the patient. Because we know all of us learn in a variety of ways. Some of us will hear the information, others will need to read the information, others will need to write the information. We're taking it past the level of just returning demonstration and nodding to say yes that you understand. We really want to transform healthcare through health literacy to ensure that this will be an aspect of health promotion, health prevention, and as well as we want to reduce hospital admissions and inpatient stays. So we want to make an impact. And in addition to that, we're taking it to the next level of community resources. How can we reinforce this information to make sustainable health of the individual? So we're trying to take it at multiple levels.
Thank you so much, Dr. Lewis. I want to recognize, before we go on to the next topic, India brings up, who is watching, and thank you so much, India. She brings up a great topic about representation in healthcare, and particularly in the mental health space, in the or in the therapy space. Before we move on to another big topic, which I'd love to, Mr. Jones to address, which is health insurance. What can we do to make sure that there is more representation, or what are universities doing to help bring about more representation in all healthcare fields? That could be anyone on the panel. I mean, you all have great experience with that.
So we absolutely have a tremendous degree of underrepresentation across the country. The percent of Black physicians is about 5% compared to a population of about 13%. We see similar numbers for Latino or Hispanic doctors. So we have to open opportunities, identify students early, have it's a multifactorial issue that starts very early on with the quality of schools and the preparation for a rigorous course of study. But it's something that with foresight and intention, identifying kids that are cultivating them for STEM careers, offering mentorship and sponsorship to help them through the long path. And, again, awareness around this issue that there is a significant disparity there in terms of the health professional workforce, and that there's evidence that having that concordance of or representation among your health professionals, you do see an impact on health outcomes. So it's a really key issue for us to tackle.
Thank you so much for that, Dr. Hernandez. Jamaal Jones, I want to talk about health insurance, especially the Affordable Care Act. It opened up access for many, giving them low-cost health insurance, but not all states adopted Medicaid expansion. Tell us why you think this is important, or what have you seen in your practice with this, Mr. Jones?
Sure. So the Affordable Care Act was passed under the Obama administration. And, frankly, many states have decided to expand Medicaid offerings because of party politics. Many states, such as Mississippi and Alabama, have decided not to offer certain benefits that are provided to individuals through government-funded access to health insurance, because of them wanting to maintain status quo with their party, even if it means that in doing so would be to the detriment of some of their citizens and constituents. Additionally, many of these states that have decided not to provide additional health insurance to the citizens of their state have done so because they felt that the services that are already being provided by the state are sufficient to meet the needs of their people.
Thank you so much. We have another great question and concern from Sam on Facebook. He himself is an African-American critical care nurse, and he wants to know, what is it going to take to get the community interested enough to attend free fairs, to make sure maybe there isn't this fear of doctors or healthcare? Any suggestions by the panel for Sam, who's out there seeming to do the work?
I'd like to address that. So Sam, thank you for bringing up a key element, because I am a critical care nurse who's trained. And in regards to that, we need to make a connection, a strong connection to why is it important. A lot of our patients really want, what can I benefit from this health fair? How is it going to help me? Because there are a lot of times that we will do blood pressure screenings, we'll do AccuCheck screenings in regards to diabetes, and we will have these various community fairs. However, these are one-time events. So how are we then going to support these individuals continuously? We can screen, but if an individual doesn't have access to insurance, an individual doesn't have access to transportation to get the appropriate preventative care, this one-time screening cannot sustain this health or promote quality of life with this particular individual. So one aspect is peer mentoring that has happened in various other healthcare diseases and diagnostic process, where individuals actually partner up together to say, this is what I've done to support my hypertension. This is what my family has done to support my obesity. We actually go out for walks as a family. It's no longer my illness, it's the illness of the group. How are we maintaining health of everyone? So really creating partnerships with other individuals that experience the same illness. It can be cross-cultural or share the same culture, would be an aspect which can help promote patients to come back for follow-up appointments. It can promote compliance with medications, and also it can help address or heighten the stigma related to a lot of diseases and illnesses. So I would say focusing on why is it important to the patient and how can it help them and their family, which if we can address one individual at a time, we can then address the community needs. But it really takes one to actually speak up and say, this has worked for me.
Thank you so much, Dr. Lewis. You know, we've talked about some of the reasons for health disparities, but now I want to turn to the cost in terms of lives. Heart disease is one of the leading, if not the major cause of death among Black, Hispanic, and white people. And hypertension can play a leading role in heart disease, especially in the Black community. Let's take a look at a video about this.
The statistics are startling. One person dies every 33 seconds from cardiovascular disease in the United States. High cholesterol, obesity, diabetes, and hypertension can cause heart problems.
African Americans, unfortunately, have the highest rates of uncontrolled hypertension in the world, which dramatically increases their risk for developing heart disease.
Dr. LaPrincess Brewer says elevated hypertension rates in the Black community can be attributed to various factors, including chronic stress, systemic racism, and socioeconomic issues.
That includes food insecurity, housing insecurity, redlining, which really limits certain individuals from receiving opportunities and resources to better their health.
She says simple lifestyle changes can reduce high blood pressure and heart disease.
Eating healthier, getting regular physical activity, getting adequate sleep, and minimizing your stress.
For the Mayo Clinic News Network, I'm Sonia Goins.
We have another wonderful viewer, Ruby on Facebook. Thank you so much for watching. Dr. Hernandez, Ruby says that she is of Hispanic heritage, and she's found that there are so few people of Hispanic heritage in healthcare. I hope in answering her question that she sees you shining there representing for all of her people, but what might we want to tell Ruby in this instance?
I understand what you're saying. We see that, and we recognize that we have work to do to continue to diversify the workforce so that it's more representative of the community, and we can provide that care that's culturally responsive and needed in order to connect with patients well and understand how best to partner with them to get them what they need to stay healthy.
Thank you so much. Dr. Denis, as our resident cardiologist here on the panel, the doctor in the video says that African Americans have the highest rate of uncontrolled hypertension in the world. What are some of the reasons for that, in your opinion?
Thank you so much. I think that's a great question because hypertension is one of, it is an important risk factor when it comes to the outcomes as it pertains to death and cardiovascular disease, heart disease itself. As was stated in the video, there are a host of different reasons as to why hypertension is so poorly controlled. One of the major reasons is stress, right? Stress from a host of different factors, including racism and other pressures, that African Americans experience on a daily basis. Right? Stress causes the release of cortisol in addition to a host of other inflammatory biomarkers in one's body. In addition to that, I think diet. Dr. Lewis alluded to some of the food deserts in our communities, and the lack of access to good quality food also leads to individuals eating foods that are high in salt content. That high salt content ultimately causes the retention of water, ultimately causes more stress on the heart, which ultimately elevates blood pressure. When your blood pressure is elevated, it puts a lot of stress on the heart, puts a lot of stress on the arteries that supply blood to the heart, and puts you at increased risk for cardiovascular disease, stroke, and heart attack, unfortunately.
Thank you so much, Dr. Denis. Jamaal, the doctor in the video also mentioned redlining, which has been outlawed since the late 60s, but it's still affecting Black people and Hispanic people and other underserved populations. Can you briefly explain what redlining is and how its legacy is still being felt in the community?
Yes, absolutely. So redlining specifically refers to a discriminatory practice involving the denial or limiting of financial services to residents who live in certain neighborhoods based on their racial or ethnic identity. The Fair Housing Act, as you referenced a few moments ago, was passed in 1968, and it made it unlawful to refuse to sell or rent after the making of a bona fide offer, or to refuse to negotiate for the sale of real estate, a dwelling, to any person because of race, color, or national origin. Oftentimes, neighborhoods that are predominantly Black, Hispanic, or of other minority descent were denied access to financial resources, leading to disinvestment, declining property values, and limiting economic opportunities in their neighborhoods. This, of course, has resulted in a vast inequality for most people of color, because one of the greatest wealth builders in this country is through land ownership. So denying people the opportunity to access funds needed to acquire property puts them at a significant economic disadvantage. If everyone were able to buy property, right, then who would have to rent it? So we've even seen Black people with similar income levels and credit ratings, when compared to their white counterparts, obtain vastly different interest rates when seeking mortgages. So redlining also has led to educational disparities, health disparities, there are many grocery stores, for example, with fresh produce, and healthcare facilities in underserved areas that are just lacking. And of course, finally, there's housing discrimination and segregation in neighborhoods that have been redlined.
Unfortunately, some of the legacy continues. We do have a comment from Facebook. Again, thank you so much for joining us. They do point out that a lot of insurance companies, ACAs, they do offer incentives, wellness programs, sometimes cash back offers, but it sometimes takes tragedy for people to take these things, even their insurance, seriously. Is there anyone that would love to comment back to this viewer about their observation?
I'd like to say that there are some individuals that are not aware of these cashback and various incentives. In addition to that, various healthcare insurance programs also offer discounts for different fitness locations. So I would say increasing awareness from different organizations so that individuals are aware of all of these things, and incorporate technology. There are individuals who have smartwatches or other devices that can actually link to a lot of these programs for the cashback incentives. And we should look and assess what is available and also promote these things at various events where individuals are renewing their insurance.
Thanks, Dr. Lewis. I want to stay with you. You know, what are some of the most important things that Black and Hispanic people can do to decrease their risk of heart disease, in your opinion, and what you've seen in your practice?
Okay, great. So some of those aspects include get up and walk. We're promoting more of a sedentary lifestyle. Get up and start moving. Whether you're doing something at home, keep moving while you're cooking. Other aspects are looking at your plate. Let's incorporate more vegetables into regards to your meals, reduce the carbohydrates, and even be knowledgeable. There are many people that are not knowledgeable of nutrition labels, for instance. Third of all, in regards to the video, reduction of stress. So that is another aspect. So we can't say on average that everyone will be stress-free, but how are you addressing stress? Are you meditating? What are you doing to help reduce and address your stress levels? So I would say those are key aspects, and also looking up information, creating opportunities where there's a hobby so you can actually continue with activity, because that is a factor. And last but not least, look about your family, address your family history. Are you aware of illnesses that you are at risk for because of first-line family members having various oncological or cancer-related issues, heart disease, hypertension, obesity? So have conversations, because that's one aspect that is limited with our fast-paced environment, to talk to family members, to talk to elders, to say, what has other people experienced? What diseases? Does grandparents have hypertension? Look into the family, to do a deep dive so you're aware of what are the things that you're at risk for.
I think you make a great point, particularly in a place like South Florida or other big cities where there are people who've migrated here.
Correct.
You know, and if we look at each other as second generation, we do have to have those talks with our family.
Correct.
Even though it's something that is not common to do, we have to make it common. Speaking of looking at history, you know, type 2 diabetes is another risk factor that can lead to heart disease, and Black and Hispanic adults are more likely than their white counterparts to develop the disease. According to the latest numbers, the rate of Black adults diagnosed with diabetes was 60% higher than whites, and they are twice as likely to die of the disease. Jamaal, lifestyle changes like eating the right foods and physical activity, the things that Dr. Lewis just talked about, can make a difference when you have diabetes. But for those in underserved communities, it's not as easy as it sounds. What obstacles, stand in their way, and are there ways to overcome that?
Yeah, so there's a number of obstacles that could stand in the way of an individual who wants to make certain lifestyle changes, but may feel stuck due to the underserved community in which they reside. This includes lack of access to healthy food, lack of opportunities for physical activity, and other sociocultural factors. As was touched upon earlier, food insecurity or food deserts, more specifically, is a lot more prevalent in redline communities that tend to have a higher concentration of Black and brown people, and communities that tend to have a higher concentration of and this makes it difficult for those individuals to maintain a healthy diet when they have to prioritize accessing any food available over more nutritious options, right? So many of those individuals work low or moderate income jobs, and some work multiple jobs to put food on the table. As a result, mom and dad need to eat out of the house more often, right? And typically this is junk food. And the children eat a lot of processed food as well as junk food, which has very low nutritional value and high sugar content. So those same communities may also lack safe and accessible spaces for physical activity, especially if the neighborhood conditions generally discourage outdoor exercise because of crime or other safety reasons.
Dr. Hernandez, speaking about some of the things that Mr. Jones just mentioned, Tawny, who's watching, says or feels that behavioral modification has to be addressed. And they also say that one cannot medicate a bad diet. What are your thoughts on Tawny's thoughts?
No, absolutely. It takes a multifactorial approach, and we need folks about what they can do to keep themselves in terms of healthy eating, and getting enough activity and getting enough sleep and not smoking and trying to avoid the processed foods, for example, I was referring to. It is not always as simple as behavior because of some of these factors, but certainly what people can control, we want to encourage them to do as much as possible, making smart choices most of the time.
Thank you, Dr. Hernandez. I want to turn to infant mortality. The rate is over twice that of white people before we start the discussion. Let's take a look at this video.
Living Minute, a look at the latest medical innovations changing our lives.
The rate of infant mortality in the U.S. has increased for the first time in 2 decades.
The latest data shows us that for an industrialized country, we still have a lot of work to do.
While overall the increase was 3%, for Black newborns the number was higher, more than 2.5 times higher than white infants.
We can't talk about infant mortality rate and racial disparities without talking about structural racism, social determinants of poor health outcomes, like where someone resides, lack of transportation, food insecurity. When patients are availing themselves for early prenatal care, we're able to provide what we call wraparound resources.
Prenatal care is important because it can catch any health complications of the mother or child during pregnancy. Also, establishing a relationship with a healthcare provider can also help the new mother get wraparound resources, which can include things like transportation assistance, health services, and other services.
Dr. Lewis, people may not think about it, but what or how does racism affect the health of a newborn baby or even the mother?
Well, in regards to racism, it starts from before the mother gives birth. Does that mother have a good level of trust with that health care provider? Is there a clear birthing plan? Are there discussions in regards to risk factors for the mother as well as the child? And then that translates into other aspects of when the mother gives birth. There are discussions and communication, and a key aspect regarding this is trust with the provider. And then third, when we transition to the postpartum or after the mother delivers, we notice that there are events where individuals who are underrepresented in the Black and brown community, healthcare providers are not as attuned to pain, to that patient saying that something's wrong or they feel something's going on. And we've seen that reflected in the media. We know that Serena Williams described aspects of her postpartum experience and how individuals did not trust what she was saying. So that all ties into aspects. If you're not listening to that mother, how can you then listen to them if they're saying my child looks different, or there's something wrong with my child, or my child was feeding and then now they're not feeding anymore. So it circles around an aspect of trust. It also circles around an aspect of advocacy. How is we as healthcare providers advocating for patients who are in the Black and brown community? So all of these aspects impact mortality rates. They also impact different complications and events that happen in the healthcare system. So that is a component of structural racism, the trust from the patient's aspect, as well as the provider listening and being attuned to what this patient is saying. And last but not least, the cultural aspect of what are the common perceptions, feelings of different patients? Because we know that some patients, when they experience pain, may not be as verbal. They may turn inward. So that is an aspect of saying, no, you're not in pain because you didn't scream. That patient may still be in pain, but they are expressing those needs differently. So just being more attuned to that, and that's how racism impacts.
Thank you. Thank you so much for that. Dr. Denis, we have a comment directly for you from Sam on Facebook. He wants to know if among your Black patients, are they more resistant to take their medications than other patients? And are there medications that will work for hypertension that maybe are better than others with regard to the Black community?
Thank you so much for that question, Sam. I think it's an important question. Amongst my patients who are of African American or Hispanic descent, I wouldn't necessarily say that they are resistant to taking their medications. I think sometimes there needs to be a bit more education that is provided as to how the medication works, and why the medication is important with regard to lowering blood pressure. Some of the deleterious effects that can take place if the medication regimen isn't adhered to. Oftentimes, some of these medications have side effects, and if those side effects aren't discussed with the patient beforehand, in my experience, I noticed that there is a tendency for adherence to be, on a decline in that regard. That being said, I would say that there's also a fear, or there is a distrust within minority communities in general with regard to non-herbals or westernized medicine in and of itself. And sometimes, that fear and that distrust, I try to meet it head on when I first meet a patient. And I try to address some of those cultural barriers or some of those cultural issues that may exist. So to answer your question, Sam, I think there's a multifaceted, a multifactorial approach that must be taken when dealing with patients of non-Caucasian communities or non-white communities as it pertains to the adherence of medication. One, the medication must be discussed in detail as to why it's beneficial for the patient. Two, the mechanism of action, interestingly enough, must be discussed with the patient to explain why the medication works and how it works. And then three, if there are mistrust or underlying issues with regard to disbeliefs or misconceptions about healthcare or the medication in itself, that needs to be met head on by the clinician as it pertains to these medications.
Thank you, Dr. Denis. And, you know, we can't have this discussion without talking about the leading cause of death among Black people and Hispanics, and that's cancer. It takes a deadly toll on all Americans, but the numbers are especially high within the Black and Hispanic communities. Black people have the highest death rate and shortest survival of any racial or ethnic group for most cancers, while Hispanic people are less likely to be diagnosed early with most common cancers and are almost twice as likely to die from liver cancer than white people. Jamaal, how does structural racism account for the increased death and disability rates among Black and Hispanic people?
Yeah, Carla, you know, this is a really tough question to answer considering the immense role structural racism plays in the increased death and disability rates among Blacks and Hispanics. For starters, the stress and trauma from experiences with discrimination, racism, and microaggressions could contribute to and or exacerbate pre-existing mental health conditions, which then can worsen someone's physiological state and lead to them developing a range of illnesses as a result. Beyond this, though, the overall disparity in healthcare access and equality can vary from person to person, but generally, when a person of color or minority group accesses healthcare, they may be subjected to lower quality care due to implicit bias, stereotypes, and systemic discrimination built within the healthcare setting itself. So why is this problematic? It's because it also leads to individuals from these marginalized communities distrusting the current healthcare system in the US, putting them at a disadvantage when it comes to seeking out any resources and increasing the likelihood of them being involved with the criminal justice system, which can then, of course, culminate in those aforementioned increased death and disability rates.
Thank you so much, Mr. Jones. And Dr. Lewis, you know, research shows that screening for cancer is lower among Black people. And are medical professionals pushing hard enough to make all of their patients aware of the dangers?
I would say yes, as a healthcare community, medical professionals are discussing these aspects in regards to screening, health promotion, and risk factors. However, as Mr. Denis explained, there are aspects regarding trust with a medical professional. So how do those aspects impact it? Individuals may not trust following up with a abnormal lab result, an abnormal diagnostic test. Individuals may also feel that their spiritual or religious beliefs can discard the opinion of a medical provider, or they can pray or believe that, you know what, we will use whatever spiritual process to get rid of this tumor or get rid of this particular issue. So that is one aspect which can then delay the individual from seeking medical attention and seeking follow-up biopsies and treatments.
Thank you so much. We have a viewer, and I thank you so much for sharing. Unfortunately, the story is that her dad was diagnosed with, or their dad was diagnosed with prostate cancer, and important levels were not checked. And before they knew it, the cancer had metastasized. So our hearts go out to you, but I do want to use this opportunity, this unfortunate opportunity, to speak with Dr. Denis. Black men die from prostate cancer more than twice as often as their white counterparts. You know, tell us what our Black men, Hispanic men can do. Should they be encouraged to participate in clinical trials?
Absolutely. I think that's a great question. And like Dr. Lewis alluded to earlier, oftentimes as it pertains to cancer, many individuals are not being screened for these diseases or these cancers. And oftentimes when they do present with cancer, they're often found to have cancer in very late stages with malignancies in stage 4. And by then, it is very difficult to manage and it's very difficult to treat. As it pertains to prostate cancer, again, it's an issue that we see far too often, where Black men are being diagnosed with prostate cancer at alarming rates, at rates far above that of their white counterparts. And when they are being
Dr. Denis, say that one more time. We're just having
misunderstanding.
We're having just a problem hearing you. You're saying some really important stuff. Can you repeat? We're having a hard time hearing you. Maybe come closer to your microphone in your computer.
Sure, most certainly. Again, I was saying that as it pertains to prostate cancer, I believe that screening is something that really needs to be promoted, because far too often African American males, when they do have prostate cancer, they're presenting with prostate cancer at later stages. And again, at that time, it's more difficult to treat, it's more difficult to manage. So there's a lot of fear that is that rests amongst the community pertaining to screening of prostate cancer, what it is, how it's treated, and ultimately how it's diagnosed. And then finally, to answer your question as it pertains to clinical trials, we know that African Americans are far underrepresented as it pertains to clinical trials. That includes trials as it pertains to medicine, that includes therapeutics, that includes devices, that includes trials from a host or a wide range of studies. So we want to increase those numbers, and one of the ways that we do that is by educating our community and letting them know that by being active and being involved in clinical trials, it helps deliver, it helps obtain, or helps individuals obtain the necessary treatments that they need at a faster and at a more effective rate. In addition to that, medications can be specifically tailored for different groups of individuals if they do indeed participate in said trials.
Thank you so much, Dr. Denis. Before we go, Dr. Hernandez, let's talk about breast cancer. While white women are slightly more likely to develop breast cancer, Black women are more likely to die from the disease. What factors do you think are involved in this disparity?
Yes, oftentimes detected with breast cancer at a later stage. Access, for example, to screening mammography, but there is also a higher rate of more aggressive breast cancer, so-called triple negative breast cancer, which tends to present earlier. It tends to be more resistant to treatment because it doesn't respond to some of the hormonal and targeted therapies that are available to breast cancer. So it can be a compounded effect there. And so we need to educate women to get their screening mammograms, to know their risk factors, to seek care if they feel anything. But we really do want to be detecting it at an early stage before it's something that can be felt. So getting your mammograms regularly.
Thank you so much. And this, we're almost out of time. This has been a great conversation, and what a fantastic panel. Do you all have any final thoughts for our audience today? Dr. Lewis.
So yes, I would like to add on in regards to what Dr. Denis mentioned. The National Institute of Health has a partnership with the National Black Nurses Association, which is the All of Us campaign. There are aspects where individuals have a stigma against participating in clinical trials, and the goal is to encourage the community to actually sign up for information regarding clinical trials that will have an impact and benefit with different illnesses. Additionally, our goal, if they have one takeaway from this segment, is to look at health promotion and actually do a deep dive to see anything that you're at risk for to improve care.
Thank you so much. Jamaal Jones, any final thoughts?
Yes. Again, thank you for having me here this evening. So what I would say is that regulatory changes are essential for addressing health disparities and ultimately advancing health equity. These changes could be made in the following areas. So healthcare delivery, anti-discrimination laws, health equity impact assessments, and environmental regulations. So examples of what each of these would look like are efforts to improve cultural competence among healthcare providers, enforcing existing civil rights laws, and implementing new regulations to tackle emerging forms of discrimination, as well as investments in impact assessments for policies or regulations geared towards promoting health equity, and placing stricter restrictions on industrial emissions or hazardous waste disposal.
I am afraid we are out of time. Thank you so much, Mr. Jones, Dr. Hernandez, Dr. Denis. Thank you so much, Dr. Lewis, and all of you participating tonight. I want to thank you for being a part of our town hall, and I want to thank all of our viewers for joining us. I'm Carla Hill, and I look forward to seeing you next time.
Thank you to the Eunice Joyce Gardner Charitable Foundation for its leadership support of the Health Channel.